All right, let's jump right in. Today, we're going to tackle a huge topic for your AFK prep: cysts of the jaws and neck. My goal here is to cut through the noise and give you a super high-yield review that really sticks.
So here's our game plan. We're going to start with the absolute basics. What even is a cyst? Then we'll cover the big ones, the most commons. After that, we'll dive into the aggressive OKC, then the imposters, the pseudocysts, and finish up with a recap table that's perfect for some last-minute studying.
Okay, first things first. Before we can even talk about all the different types of cysts, we have to lock down the one fundamental rule. This is the rule that separates a true cyst from everything else that just looks like one. And here it is this. This is the definition you have to burn into your memory. A true cyst is a pathologic cavity that is lined by epithelium. If you don't have that epithelial lining, it is not a true cyst. Period. This one little detail is absolutely critical for getting the diagnosis right. Let's move on to the two heavyweights. I mean, you are pretty much guaranteed to see these on your exam and definitely in your clinical practice. These are the champions of odontogenic cysts. So first up is the periapical cyst. You'll also hear it called a radicular cyst. This is, without a doubt, the #1 most common cyst in the jaws. And its story always starts with inflammation from a non-vital tooth. That chronic irritation kicks the rest of Malassez into gear, and boom, you've got a cyst. Next, we have the dentigerous cyst. Now, this one is the second most common overall, but it's the most common developmental cyst, and that's the key difference, right? The periapical was all about inflammation. The dentigerous is all about development. It comes from the tissue around the crown of a tooth that just hasn't erupted yet. This table just puts it all together perfectly. For the exam, you've got to have this down cold. You see periapical, you think inflammation, non-vital tooth. You see dentigerous, you think developmental, unerupted tooth. Nailing this distinction is going to get you a lot of points. All right, now it's time to talk about the antagonist of our story. This is the cyst that really demands your respect because it's aggressive, sneaky, and it has this incredibly frustrating habit of coming back. I'm talking about the odontogenic keratocyst, or OKC. So there are 4 things you just have to know about the OKC. First, its behavior is aggressive. It tends to grow along the inside of the bone without really expanding it, so it can get huge before you even notice it. Second, that crazy high recurrence rate. Third, it comes from remnants of the dental lamina. And fourth, it has a really important link to Gorlin-Gold syndrome. Let's talk more about that recurrence rate. We're talking up to 30%. And here's the thing, it's not always because of bad surgery. The lining of the cyst is super thin and delicate, which makes it really hard to get out in one piece. Plus, it can form these tiny little satellite cysts right next to the main one, and if you miss one, it's gonna come back. Okay, this right here, this quote is the absolute dead giveaway. This describes the unique histology of the OKC. If you are reading a question on your exam and you see the phrase palisaded basal layer, just stop. The answer is OKC. It's the microscopic smoking gun. Now, let's switch gears and talk about the imposters and the outsiders. We're going to look at pseudocysts, the ones that break our main rule, and then we'll look at a key cyst that shows up in the neck. So remember that #1 rule we started with? The whole epithelial lining thing? Well, pseudocysts are the reason we have to be so strict about it. On an X-ray, they look just like a cyst, but when you actually get a sample, guess what's missing? That epithelial lining. They're the great pretenders. For the AFK, you really need to know these two. First, the traumatic bone cyst. It has this classic look where it scallops up between the roots of perfectly vital teeth. And the treatment is wild. You just open it up, make it bleed inside, and that's what triggers the bone to heal. Then you have the static bone cyst, or Staphny's defect. And plot twist, it's not even a pathology. It's just a little dent in the jawbone. So what's the treatment? Absolutely nothing. You just leave it alone. Okay, finally, let's step outside the jaws for a second. The most common developmental cyst you'll find in the neck is the thyroglossal tract cyst. It's usually right in the midline, and here's the classic clinical sign, the thing they'll put on the exam. The lump moves up when the patient swallows or sticks their tongue out. Phew. Okay, we have covered a ton of ground, but now we're going to boil it all down into one powerful slide. Think of this as your ultimate study snapshot, perfect for that last-minute review right before you walk into the exam.
This table is pure gold. It lays out these beautiful, simple patterns for you. Just look down the vitality column. Notice how only one of these, the periapical cyst, is tied to a non-vital tooth? That's huge. And those keywords on the right, those are your triggers for exam questions. Use this table to connect the dots, and you're going to be in great shape.
And I'll just leave you with this final thought. A question to really make it all click. The answer, of course, is the OKC. And this just highlights a super important concept. Understanding what's happening under the microscope isn't just for academics. It directly explains why a lesion acts the way it does clinically and tells us how to treat it. That's why this stuff matters. Good luck with your studies.